Hello guys, welcome to your own clinical YouTube channel. Today we'll be discussing an interesting topic, that is hypoxic pulmonary vasoconstriction, right? So basically it is a protective physiological reflex to hypoxia. And what does it do? It just diverts blood from hypoxic region to normal lungs area, or areas with a better ventilation perfusion matching, so that overall oxygenation can be improved, right? So it's a physiological reflex to hypoxia which diverts blood from the hypoxic region towards the normal lungs area or areas with a better ventilation perfusion matching. And it was described by Davis et al. In 1981 after his animal experiments, right? So what is the role? Does it have any significance in healthy individuals? So in healthy individuals its role is minimal in healthy and normal lungs, right? But in pathological processes like some acute and some chronic diseases like COPD and interstitial lungs disease, its role is definitely there. Also in asthma or pneumonia or pulmonary embolism or pulmonary edema, it helps in maintaining a better ventilation perfusion matching by diverting blood from hypoxic region to normal, better ventilation perfusion matching, right? So in this kind of disease conditions we need to take care of few things, like in COPD or ILD, when we are giving a high FiO2 or high oxygen, it hampers the hypoxic pulmonary vasoconstriction, shunt increases, and overall VQ matching is hampered, which leads to clinical deterioration, right? So let us understand the mechanism behind it. So various theories has been proposed to define the exact mechanism, but the most widely accepted theories goes like this. It involves oxygen sensing to hypoxia, right? One hypoxia occurs. First there is oxygen sensing, then some regulatory molecules get involved, and the final step is vasoconstrictive action, right? So the oxygen sensing mechanism involves some potassium channel, and some theories say some mitochondrial reactive oxygen species play a definite role. Some say it's hypoxia inducible factor, and some cellular energy change, and some other theories are there. And this oxygen sensing mechanism finally leads to some regulatory molecules. Those are nitric oxide, prostacyclin, and endothelins. And you must have known the potential therapeutic agents acting as an agonist or antagonist in this kind of receptors, and which ultimately leads to vasoconstriction, simply rise in intracellular calcium and actin myosin breathing mechanism, nothing more than that, right? So what happens, let me draw a simplistic diagram for you. Let us consider two alveolar units, A and B. In A there is hypoxia or less oxygen, and B is well ventilated and oxygen tension is more, right? So what happens, the sensing mechanism senses the decrease in oxygen tension, then regulatory molecules get involved, which ultimately leads to vasoconstriction, right? Then what happens, blood is diverted from the region A to the region B, right, which overall improves oxygenation and better VQ matching, right? So what is the stimulus for the hypoxic pulmonary vasoconstriction? So generally it can be defined by a formula that is also derived from the animal studies, that is expressed as P stimulus O2 equals to PaO2 per 0.62 plus P mixed Spanish O2 per 0.38. This PaO2 is alveolar oxygen tension, and PvO2 stands for mixed venous oxygen tension, and the PaO2 contributes almost two-thirds, and the mixed venous oxygen tension one-third, right? So what happens, let us understand. When a lungs is being ventilated and segment is being perfused, the stimulus for SPB to get activated is majorly determined by the two-third component, that is the PaO2, and the one-third component of the mixed venous oxygen tension, that is in pulmonary artery, right? So what happens when there is no ventilation and only perfusion, that means the areas with shunt, this component is absent, and the the stimulus is directly dependent upon the one-third component, that is the central venous or mixed venous oxygen tension, right? So this is the oxygen tension, not the oxygen content, that is determinant for hypoxic pulmonary vasoconstriction, right? So it's oxygen tension, not the total oxygen content. So it happens in a biphasic manner basically, right? So what happens, initial phase 1 and later it's phase 2. Phase 1 gets activated within seconds of hypoxia, right? And it reaches a maximum vasoconstriction at around 15 minutes. It's maximum, right? Then as time passes, 30 to 60 minutes it enters in phase 2. So phase 2 reaches a peak at around 2 hours, right? So what happens if normal oxygenation is restored? Does it get back to the normalcy immediately? No, it takes at least several hours for normalization, right? It is a very important topic for particularly edic examiners, right? Especially in part 2. So what is the predominant mechanism for phase 1? It is the potassium channel for phase 1, and it's the endothelin mediated mechanism for phase 2, right? Let me summarize it again. So it's a biphasic response, phase 1 and phase 2. Phase 1 gets activated within seconds of hypoxia and reaches a peak of around at 15 minutes, right? So as time passes, after 30 to 60 minutes, it enters in phase 2 and it has a peak at around 2 hours, right? Phase 1 is potassium channel mediated and phase 2 is generally endothelin mediated. And after normoxia is achieved, it gets normalized only after several hours, not immediately, right? So what are the factors those influence this protective reflex, right? So some factors are there which potentiate or increase this effect, and some attenuate this effect, right? So let us understand one by one. Acidosis, it potentiates, and alkalosis, it decreases or attenuates the effect, whether it is metabolic or respiratory. Again, it's hyperthermia which potentiates, and hypothermia which attenuates the SPB, and it's maximal or is potentiated during infancy, right? And it decreases with age. In older ages as compared to pediatric population, or in during infancy, it is decreased. Also, interestingly, iron deficiency potentiates the SPB. So overall iron status, whether it is deficient or patient is on iron therapy, depending upon these factors, SPB is influenced. So with iron deficiency, it is potentiated, and patients on iron therapy, some experimental models have already proved the fact, and patients with iron therapy, the SPB effect is attenuated, right? So it is appropriate to have adequate iron store, and it is important particularly in patients with pulmonary arterial hypertension, and patients with prolonged hypoxia, or patients with on high altitude, right? So other parameters like sepsis, what happens in sepsis? It inhibits or attenuates the protective HPV response, right? Sepsis or some localized infections, they attenuate this response probably via a nitric oxide mediated mechanism, right? So some therapeutic agents which have effect on pulmonary circulations. some pulmonary vasodilators, and some pulmonary vasoconstrictors. Generally, the vasopressor we use having alpha agonistic action like ADR, NORAD, and adenosine. Adenosine, it is important, it comes as an MCQ. It is a pulmonary vasoconstrictor. And vasodilators we use therapeutically: nitric oxide, milrinone, levosimendan, sildenafil must using, and vasopressin. Remember, noradrenaline is a pulmonary vasoconstrictor and vasopressin is a pulmonary vasodilator. Then you must be using bosentan, and as we had already discussed, prostacyclins, also calcium channel blockers and ACE inhibitors. Right. So these are some potential therapeutic options which vasodilates the pulmonary circulation. Right. So read more about it. We'll see you in next video. Thank you.